Okay,
Okay.
ladies and gentlemen, welcome to this, the latest offering in the 2025 Red Lion Group webinar series, an immense series. I've got the undoubted pleasure as chairman, David Davis, chairman of Red Lion Group, of introducing tonight's speaker, who's Clemmie Oliver, with great thanks to Gary for pressing all the right buttons, and also Christopher Brown, who arranged the meeting in the first place. So great thanks to them. And of course, in a moment, I'll be introducing Clemmie, who's an absolute superstar and has agreed to give up what are we, Wednesday evening to deliver what I hope will be I'm sure will be a fantastic talk. All right, so Clemmie's a expert in nutrition and dietetics, and has got an MSc from the University of Aberdeen, and with a specific focus on nutrition and dietetics for people who are suffering from IBD. So that would be ulcerative colitis and Crohn's disease. So very, very specific knowledge. And also, may I share that Clemmie herself has a pouch. So that puts her in a fabulous position to be able to understand the challenges that face pouchees and potential pouchees in terms of nutrition and dietetics. So there's four things that Clem is going to be covering, but I'll leave her to talk about that because you don't want to listen to me. All right, this is not it's not for me. But we're going to ask Clemmie to talk for a while, and then there'll be time at the end for questions, and we hope to get as many questions in as we can. So once again, thank you for joining. I'll hand you over to Clemmie. Clemmie.
Thank you very much, David, for the introduction, and welcome everyone. It's such a pleasure to be here this evening, and such a pleasure to be talking to so many people who are fellow pouch people. As David said, I specialize in nutrition for inflammatory bowel disease, but have an extra special interest in supporting J-pouch and internal pouch patients, and work with patients with pouches all over the world. And I seem to, I guess, attract other pouch patients because I have the personal experience as well as the clinical experience. So it's such a pleasure to be here this evening to share some snippets of knowledge, and to hopefully support you on your pouch journey. So I have got some slides because I thought it would be easier to illustrate what I'm talking about. So what I'm just going to do is share these and hope that it's going to behave itself. I just wanted to double check that you can see the slides.
Yes, indeed, we can. Yeah.
Brilliant. Okay. So I have been introduced, so I feel like I don't really need to say a lot more, but I do have a specialist clinic, the Nutrition and Lifestyle Medicine Clinic, and we work virtually with patients all over the world with inflammatory bowel disease, but also, as I said. Yeah, I'm a registered nutritionist, registered nutritional therapist. I also am nutrition advisor for Crohn's and Colitis UK, and also a company called IBD Relief. I'm ambassador for Bowel Disease UK. And as has already been alluded to, I also have a J-pouch myself. So I guess just a little background, because often patients ask like what my personal story is. I was diagnosed with ulcerative colitis aged 9. Was diagnosed with pancolitis and had a very, it was severe and nothing seemed to get it under control. And actually, when I was diagnosed, none of the wonderful biologics that exist now existed back then. So within 2 years, I had my colon removed and I lived with an ileostomy through my teenage years. And when I was 18, I went back under the knife and had a two-stage pouch surgery and have lived with a pouch now. Gosh, that must be like 15 years ago. I'm 35 now. So that's just a little bit of background. And I realized very late on in my journey how important nutrition can be for quality of life with IBD and with a pouch. And I also realized that other people were finding that they weren't getting the support. So I trained in the area of nutrition and specialized in inflammatory bowel disease and set up my private clinic to support people so that no one else found themselves in a position where they didn't have anyone to talk to when it came to dietary support. So that's why I'm so passionate about this topic. Anyway, we move on to the exciting stuff. So what are we going to cover today? So this is a huge topic, nutrition and pouches. I could talk all day about it, but we only have about half an hour, 40 minutes, and I've been given strict instructions to stick to the time frame. So I have tried to pick out some important bits. I can't cover it all in one session like this, but I'm going to give you a good overview. And hopefully some practical stuff too along the way to help to support you. So we're going to be talking about why is nutrition important with a pouch. We're going to be talking about the importance of diet just post-pouch surgery. We're going to be talking about what happens after surgery and our ongoing diet living with our pouches. And also I've included a small case study to kind of bring it a bit to life in terms of what I'm talking about. And then we've got time for a Q&A at the end. What I also wanted to say right at the beginning is none of this is personalized advice. Every person is unique and everyone will have unique symptoms that they're dealing with, unique perhaps complications or anything. So this is not substitute for any medical or nutrition advice you're already getting on a personalized basis. So first and foremost, why is nutrition and why is food so important? So nutrition is important for absolutely everyone. And I get very frustrated when I hear a lot in the kind of IBD space, but also in the pouch space, when people say, oh, diet doesn't make a difference to your disease, diet doesn't make a difference to your condition. When actually we have an abundance of research now to show us that it really is very important. And we have research in the pouch space as well to suggest how important it is, and I'm going to talk about that today. And also, no matter whether you have a pouch, a medical condition or not, diet's important for everyone, no matter who you are. And it can be the difference in terms of us having a healthy, balanced diet and having an unhealthy diet. It can really make a difference to not only how we feel on a day-to-day basis, but also actually our risk of future conditions, lifestyle conditions like type 2 diabetes and cardiovascular disease, and even certain types of cancers as well. So it's absolutely vitally important for everyone. Now, when we have a pouch in particular, actually having a pouch in itself can put us at risk of certain nutrient deficiencies. And I am going to cover a bit later in my slides what are the most common ones and also the symptoms associated with that. So you can have a think about, oh, do you get those symptoms or not? And if you do, maybe it's something that you need to ask your care team about. Maybe that's your GP or your surgical team or whoever you're under at the moment. If you're getting those symptoms, then it might be worth getting some tests done to correct those. And I'll talk a bit about why that is as well. And what we eat and drink can affect our pouch and our digestive system in lots of different ways. So what we eat and drink can affect the speed at which food moves through our intestines. So it can either speed things up or it can help to slow things down. And that is really important when we're trying to manage our pouch and we're trying to live our lives and not feel like we need to be next to the loo all the time. Food and drinks can also affect how much water is drawn into our small bowel, but also how much water is drawn out of our small bowel. And again, that really makes a difference in terms of the consistency of the stools that are coming out of our pouch. And again, that's important in terms of control and urgency and us being able to live our lives. Also, food in particular can affect something called our pouch microbes. So you might have heard, it's been in the news a lot recently about the gut microbiome. Now, they are, for those of you who don't know, I don't want to teach grandmother to suck eggs for people who do know, but for those of you who don't know, there are trillions and trillions of microbes. So that's bacteria, viruses, yeasts that live in our colon, if we have one. And they basically help to keep us healthy. And they eat the food that we don't digest, which is fiber. And when they eat that food, they produce lovely compounds that help to keep the environment in the colon a healthy one. And they produce some of the compounds they produce help to reduce inflammation as well. Now, if we don't have a colon, but we have a pouch, actually what our understanding is at the moment from the research is actually that pouch has its own little microbial colony. And actually, the food that we eat can help to support that microbial colony to keep it healthy, and again to produce those compounds that help to reduce inflammation and help to keep the pouch a healthy environment. And again, that's really what we want to be doing to try to help potentially reduce our risk of things like pouchitis. And you'll see there's some research that I'm going to share in a minute that suggests that diet may actually help to reduce our risk of pouchitis. And the reason why we understand that the kind of diet and microbes and how they might be important in a pouch is, in terms of the treatment of pouchitis, it's antibiotics. So it's destroying and killing off those gut microbes in the pouch, which then helps to reduce inflammation if you've got ones that are interacting in a way that they're not meant to. But actually, if we can support a healthy pouch community, then that is going to be helpful in terms of supporting overall pouch health and supporting our overall health as well. So all these things come together and can affect the amount that we empty our pouch, the consistency of the stools that are coming out, and our pouch function and health. And where diet can also be really important, so it can support our pouch health, but actually we can help to manage some symptoms that might come up. So things like loose bowel movements, gas, pain, bloating can all be really, we can try and tackle them through changes in our diet. So I don't know how many people here, I wanted to kind of cover all bases. So I don't know how many people here are pre-pouch surgery. I don't know how many people are just post-pouch surgery or people who are long-term. So I wanted to share kind of if there's anyone here who is, or anyone watching a replay, if they're going into surgery or just after surgery, I wanted to make sure that I shared some information. So in terms of like the journey through the pouch. So post-surgery, you will be advised by the surgical team to follow a low fiber diet for a period of about 4 to 8 weeks. Often it's kind of the 6-week mark. It really depends on how your progress is post-surgery and any complications that you're having. You will be told to follow that low fiber diet. So that's things that are easily digested and absorbed through the bowel. And if there's any swelling, we need to make sure that that food can pass easily through that healing bowel, basically. Now, in terms of like what a low fiber diet actually looks like, lots of people that we see in our clinic are under the impression that that means beige, basically. And actually, it doesn't have to be beige. There's lots of different things that we can still include, which means that you have the healthy, balanced diet, which actually is really, really important for recovery post-pouch surgery. So an example is that actually post-surgery, our protein requirements increase quite a lot. So actually pre-surgery and post-surgery. Obviously, when we have surgery, there's tissue that is damaged and cut up and put back together in the process, and we need to help make sure that we're supporting that healing. So it's a little bit about like knocking a wall down outside your house. You need to make sure that you have the bricks and cement to rebuild that, and that actually comes from the protein in our diet. So we really need to make sure that we're including enough protein, but also other nutrients like zinc and vitamin C, for example, that really help to support recovery. So when we're talking about fiber, there's actually 2 different types when we're following a low fiber diet that we need to be considering. So one is insoluble fiber and the other is soluble fiber. So quite simply, soluble is dissolves in water and it forms a gel, and insoluble is it doesn't dissolve in water. So if I kind of bring that to life visually for you, there's a couple of different analogies that I use, and I'll share the different ones with you because different ones will resonate with different people. So if we take an apple as an example, if we took a bit of the peel off and we popped it in a glass of water, and then we took a bit of the flesh out of the inside and we popped that into another glass of water and we left that for a period of time, over time, that fleshy bit would dissolve in that water and it would form a gel, whereas the skin wouldn't and it would stay intact. So the fleshy part of those plants is that soluble gel forming fiber. The insoluble is the skin, seeds, pips that don't dissolve. And another analogy I often use is anything that collects in the sink plug hole when you're washing up, or anything that collects in the dishwasher, at the bottom of the dishwasher, over time, that will be insoluble. It just doesn't dissolve in water over time. And then the other one can be a sieve, for example. If you put something in a sieve and you massage it with the back of a spoon for a while, if over time it would actually dissolve through that spoon, it's soluble. If it doesn't, it would be insoluble. So again, examples: insoluble is whole nuts and seeds, big thick plant skins, that kind of stuff. Whereas your soluble is your gel forming, like think about bananas, apple, like the fleshy bits of apple or stewed apple, those kind of things are those soluble fiber. So it's really important that we continue to eat that healthy, balanced diet to support that recovery post-surgery. And in terms of actually being able to include those fruits and vegetables, it is good for the carbohydrates to stick with things like our white bread, our white pasta, those kind of things. But it doesn't mean that we can't include some fruits and vegetables. So often tinned ones are quite good, and we should get the tinned ones in water. Because they're tinned, they've been sitting in the water for a long time. They're really, really nice and soft. Also, we can cook things at home. So as I mentioned, something like stewed apples or cooked pears or something like that can be a really nice option that you can still include, but just remove the skins and any pips as well in it. And also another one that we can do is we can blend things. So generally, we can include some fruits and vegetables that maybe we wouldn't eat whole if we blend those down into soups and smoothies. And that can be really helpful, not only just post-surgery, but actually I find that helpful for some other patients who are finding that they're having problems even post-surgery. So hopefully that gives an overview of that. I have to make sure I keep an eye on time. So what are we looking at then in terms of like our ongoing diet? So we've been given the all clear post-surgery, and we are then let loose into the big wide world with often what I see is not very much dietary support. And you'll see from the case study that I've included that that was the case for the patient that I saw quite recently. So what do we do then? What happens then? So in terms of the research, there was some research published in 2020 in the European Journal of Nutrition, and that's reported that following a Mediterranean dietary pattern was associated with decreased calprotectin levels and lower rates of pouchitis over time. And there was also another study published the year before in 2019 that found that fruit consumption, interestingly, was correlated with better microbial diversity in the pouch. So basically a better pouch environment in terms of those little microbes that are there to keep the pouch healthy. And as a result of that, they saw lower rates of pouchitis. So we don't yet fully understand exactly why this dietary pattern, the Mediterranean dietary pattern, is associated with better pouch health, but we think that it's something to do with the fiber and the antioxidant content, particularly of things like fruit. However, what we do see in the research as well, and what I see every single day in clinic when I'm working with pouch patients, is that as pouch patients, we often tend to have a significantly different diet to a Mediterranean diet and to healthy individuals, and particularly so when we have pouchitis. So we definitely see often much lower fruit and vegetable consumption. And that is often through maybe miseducation or communication from dietetic teams on discharge from hospital, but it can also be because we are afraid to introduce foods and that we stick to our safe foods, or we found that foods might have triggered symptoms at one point and then we haven't reintroduced those again. Now, in terms of kind of the research, because J-pouch, because we're not a super common patient group, like there are quite a few of us, and it's so great to see so many here this evening, but there isn't loads and loads of funding that goes into pouch research. So we still need lots more data in this, and there are limitations to the studies that we have. However, what we know is that really practically following this Mediterranean dietary pattern can have multiple benefits on our health beyond our pouch health. So we know that the Mediterranean diet can reduce the risk of things like heart disease and diabetes. And most importantly, we know that it is safe as an intervention. So in terms of like what actually is this like term, the Mediterranean diet is banded around loads. And like, what does it actually mean? So following a Mediterranean diet encourages the consumption of plenty of fresh fruits and vegetables, whole grains, lean proteins, and is low in processed foods, low in refined sugars, and lower in red meat. So you see here, this is quite a good description in terms of the pyramid, that we can see the kind of majority of the diet in terms of the Mediterranean diet is the fruits, vegetables, grains, oils, nuts, seeds, that kind of stuff. And then as we move up, it goes like slightly less, so fish and seafood. And you can see, actually, you can't see super clearly, but it says at least kind of 2 portions a week next to the fish and seafood, and then it goes up and up and up. Now, in terms of the kind of other extra stuff when it comes to the research in pouches, is that the data suggests that actually what we should be doing is focusing on low saturated fat protein sources. So rather than like our red meats and our processed meats, actually focusing on things like poultry, eggs, fish, seafood is a good option. And also limiting alcohol consumption is also potentially quite helpful in reducing pouch symptoms. And that's something I see quite regularly in clinic as well. However, lots of people that I would talk to about with a pouch about that would say, yeah, that's all well and good. However, how do I eat like that with my pouch? Because I can't eat like that at the moment. Or when I eat that, it triggers my symptoms and actually I'm stuck in this place. And I understand that because I've been there myself. And there are ways, and I do this a lot with the patients that I work with in clinic, there are ways that we can adapt the Mediterranean diet. So we can expand your diet out as much as possible to be as much in line with the Mediterranean diet as we can, while still managing symptoms and while still making sure that we're not increasing pouch output too much and making you go to the loo all the time, because that's not what we want to do. We want to make sure that we are keeping the frequency down as much as possible so we can live our lives and not be near the loo all the time. So I just wanted to share a few little snippets of things that might be helpful if we're looking to transfer away from a more beige diet onto a Mediterranean diet, or if there's foods perhaps that you have excluded for a long period of time and you want to retry them, then these are the kind of tips that might be helpful in order to do that. So what we can do is if you haven't had fruits and vegetables for a while, is actually increasing them really, really slowly is helpful. If we suddenly go from a certain way of eating to completely changing it all in one day, it's probably not going to go that well. We're probably going to get symptoms just because our system's just really not used to it. So what we often suggest to people to do is actually just trying one new portion of fruit or vegetables every 2 or 3 days. So just take it super slowly. And often with this, we'll equip patients with the tools, and it might take patients 6 months or so to really expand their diet out, because it takes a bit of time to include stuff. Some patients, actually, it's really quick. We might give them a list of things to do, and they might say do it every 2 or 3 days for 2 weeks and find that actually they haven't found anything so far that is impacting them and everything seems to be fine. So they go a bit quicker with that. So that can be a really useful thing to start with. Also, when we're starting with those portions, if you're finding that you're getting symptoms with a whole portion, actually, or you don't feel confident, maybe you're a bit worried because you haven't had that food for a while, or you had a bad experience with it once, actually, why not try just having like a quarter of a portion or a third of a portion? Then the next time, if that goes down okay, the next time try 2/3 of a portion. And if that's okay, again, the next time try a whole portion. And you can break that down into however many little increments you want to help you feel more confident and to help this be a successful reintroduction. And again, when we're first reintroducing things, sometimes it can actually be quite helpful to adapt those textures. So even if we are not just post-surgery, even if we're years post-surgery, sometimes, again, it can just be helpful. And also, what I tend to find with people is if we can't tolerate a food raw, actually, it may be that we can tolerate it cooked or mashed, and that's fine. And that's how we still include that food going forwards. So we can cook foods, we can remove skins, we can blend them. So for example, I often see lots of people with pouches avoiding whole nuts, but actually that doesn't mean that you can't include any kind of nuts in your diet. Actually, we can use nut butters, we can use ground nuts as well, so like ground almonds, for example, that you get in the baking aisle. And again, soups and smoothies can be really helpful to get in foods that perhaps you don't feel like go sit that well with you whole, but actually in a blended form, they seem to be okay for you. So they're just some little tips that may be helpful, because it can feel quite scary for someone to be like, yeah, just eat the Mediterranean diet. And actually, our job in clinic is to coach and support people through this and give personalized advice in terms of what their diet looks like currently, what their symptoms are, what their complications might be, and then we support them in terms of a plan that works best for them. Oh, and then the last one on here is actually like focusing on those soluble fiber foods. So in terms of actually, if you find that your bowel movements from your pouch are actually quite watery all the time, and you do have quite a low fiber diet, sometimes actually introducing things like some oats, avocados, root vegetables, those kind of things that have that lovely soluble fiber in them, that can actually help sometimes just to thicken that output. As I said, in terms of the soluble fiber, when they go into the digestive system, they actually absorb water. They act a bit like a sponge, and they form that gel, and they basically stick the stool together. And then it actually moves slightly more slowly through the system. And I see that being a really effective thing to help support people to just reduce the amount of times that they're going and to thicken things up. Just in terms of, I often get asked about what we should be doing in terms of like frequency of eating, and it very much depends on you as an individual. Some pouch patients I find really work quite well with just 3 solid meals. Some patients actually work well with like 3 meals and 2 snacks. What we often find in the advice from the research is actually consuming slightly smaller, more frequent meals rather than big, large meals. Some people can find quite helpful. And again, in terms of reducing how many times we're waking up at night, if we can eat supper 3 hours before we go to bed, that can often help. And that can also help if we're experiencing nocturnal seepage or anything like that. Sometimes that can be helpful as well. And then in terms of like improving consistency, as well as those soluble fiber foods, the like really classic foods are like banana, potatoes, rice, bread, yogurt, those kind of things can be really helpful as well alongside foods. I'm conscious of time, so I'm gonna crack on through these. It's amazing how much there is to say and how long it takes. So in terms of symptom triggers, it is really important to remember that it takes a bit of time for a new pouch to settle. So it's around kind of 6 to 12 months that it can take to settle down. And I know it's really frustrating when perhaps we've waited for a pouch for a long time and actually just want to get going and carry on with your life and do everything that you want to do. But you just have to be patient and compassionate with yourself, that actually the new pouch and the new structure, like it's just gonna take some time to settle down. But if you're finding like after that period of time or during that period of time that there are specific foods or drinks that you think every time I eat that doesn't really work that well with my pouch, then actually it can be quite useful to identify those and swap or adapt accordingly. And what I wanted to share in the slides is just some really common ones that we tend to see and some simple swaps so that you can still have a diverse diet. And that's really like my ultimate goal with all of the patients I work with, is how can we include as many different foods as we possibly can in your diet to mean that you can have as normal a life as possible around diet. Because if we can have a normal life around diet, it's easier to go out, it's easier to eat with friends, it's easier to go out for dinner, and we want to try and do that as much as possible. So I'm just going to whiz through these. So I often see in clinic, and it's well documented in the research, that caffeine, like particularly coffee and some caffeinated drinks, can increase bowel movements and urgency. And I sometimes see patients that perhaps weren't made aware of this. So actually what we can do is switch to herbal teas or caffeine-free drinks instead. So we're still getting that hot drink, but it's just not going to have that bowel stimulating effect for us. And what I tend to see in pouch patients actually is in patients with an entire colon, usually you'd have a cup of coffee and then within about 5 minutes it might trigger a bowel movement. I tend to see sometimes in pouch patients that the effects can be a bit longer. So it might affect you for more of the day and more of your bowel movements. So with spicy foods and chili, I'm sure maybe you have or have not experienced this, but I guess non-technical word is butt burn. But it doesn't mean that we can't have flavor in our food. So if we have spicy foods, it can cause that butt burn when we go, which, as I am a pouch patient myself, I know is takes your breath away type pain, and urgency and increased bowel movement. So actually what we can do is, why don't we choose like aromatic spices? So things like turmeric, cumin, those kind of things. And also herbs as well. So fresh parsley, basil, those kind of things, pestos, that kind of stuff. So you still have some flavor for your food. It doesn't need to be completely bland. And then whole nuts and seeds. As I said, I often see people who avoid those, but actually if we can introduce things like smooth nut butters, ground nuts, ground seeds, that's fine. Also, what I would say to you is with these, not everyone has problems with all of these. These are just like examples of things that I see quite commonly, but actually I know plenty of pouch patients who eat whole nuts and seeds totally fine. They don't cause any issues for them at all. If you're experiencing, when you have things like milk, cream, and ice cream, looser output from your pouch, more gas, things like that, actually it might be worth trying lactose-free or low lactose dairy or fortified alternatives, so plant milks that are fortified with calcium. And then legumes, so things like beans, lentils, and onions and garlic as well. Often people might find that they get bloated and gassy. So sometimes it can help to improve tolerance by blending these things in. So legume flours, legume pastas, but also actually just having quite small amounts to start with and then increasing the amounts you have over a period of time. Sometimes it takes weeks, sometimes it takes months to improve tolerance to those things. But we can often get to a place where maybe we can tolerate some more of those. But they're kind of classic kind of bloating and gassy type foods. So I said I'd cover the nutrient deficiency risk. So these are the 4 really common nutrient deficiencies that we see for people with pouches. Now, I want to draw your attention here specifically to B12 deficiency. So the reason why this is really common is that in terms of quick anatomy lesson, we have our food pipe, our esophagus, and then we have our stomach, which churns our food around a bit, and then it goes into our small intestine. And the small intestines, if you see like an image of someone's insides, is the wiggly bit in the middle, and then that's at the end of the small intestine is what the pouch is made out of. Now, interestingly, different nutrients are absorbed at different locations along that tube of the small intestine. And some nutrients, but particularly vitamin B12, is only absorbed in the last bit of the small intestine, and part of the last bit of that small intestine is fashioned to make our pouches, which means actually for some people the surface area for absorption of B12 is actually a bit less, and that can put us at risk of deficiency of B12. And what I always recommend that people do is that they have a blood test for vitamin B12 about 6 weeks post J-pouch op. If we can get a pre-surgery, that would be really good because then we can compare it. We do a 6-week post-op, and then we do a 3 months after that. And then if that's okay, 6 monthly after that, and then we can go to a year. And the reason why that is that we store vitamin B12 and our stores last about 3 months. So if someone stores a fine pre-op, if we wait until 3 months, someone's stores might be completely depleted, which is why I often say if we can get a test at 6 weeks, that's really good because we can see where are those B12 levels at. Have they dropped quite a lot, or are they remaining stable? Again, this isn't a problem for everyone, but it's a problem that I see being missed in quite a few patients, which is why I wanted to bring it up. If you do have problems with B12, sometimes injections are needed. And iron deficiency anemia is quite common as well, vitamin D deficiency and zinc deficiency. So maybe you can take a screenshot or a photograph of this slide. And if you experience any of these symptoms, maybe you can have a chat to your GP and just say, I'm at increased risk of deficiency, please, can you test my levels? And it may be that then you discover there is a deficiency, which you'll see in my case study we did, and that can improve symptoms dramatically. I appreciate that I'm now going over time. Am I okay just to continue for a few more slides?
Yeah, absolutely. Really good. Thank you.
Okay. I promise that I won't take too much longer. New or continuing symptoms. So if you are having ongoing issues or you start having new issues with fatty foods, with lactose, so that's found in dairy products like milk and yogurt and soft cheese, or if suddenly you go from actually your pouch seems to be fine to more frequency, more urgency, pain, changes in your pouch function or your symptoms, it's actually really, really good to get that all looked at, basically. So it may be that there are other problems alongside your pouch, for example, with the fatty foods or with the lactose, maybe lactose intolerance, that can be diagnosed, and then you can get the right support to help with that. And I often see patients who aren't given the right care pathway or aren't told what to look out for when it comes to pouchitis post-surgery. And I get lots of patients coming to me being like, I'm having loads of problems with my pouch. It seemed to be fine for ages and now it's not. And I'm like, right, first things first, before you even start working together, we're going to your GP, we're getting a fecal calprotectin, which is a stool test that looks for inflammation in the pouch. And we see, does that show inflammation or not? If it shows inflammation, then that indicates that there may be some kind of pouchitis and that needs to be investigated and treated. So it's really important that if you notice any new onset symptoms or symptoms around food, that you get help and support with that. Okay, case study, and then we're going to move on to the Q&A. So I saw this lovely lady in my clinic quite recently. She's 45. She had pouch surgery 15 years ago, and came to me because she was really worried. She was on a very restricted diet based on the advice and guidance that she was given in hospital, because she wasn't given any follow-up dietetic support, which again is something that I see really commonly. She, as in not post-surgery, she had then tried to see some dietitians, but none of them had any J-pouch knowledge. And I think one of the dietitians that she saw said, I don't know what a J-pouch is. She didn't get the correct follow-up dietetic support for someone who knew what a pouch was and how we support them. She was having really frequent watery bowel movements. She was going 10 to 15 times a day, and was finding that it was quite urgent as well. We made sure that we ruled out pouchitis being an issue, and she also was experiencing lots of fatigue as well. And as I said, she was worried about her ongoing health issues on her very restricted diet. She wasn't able to eat the same meals as the rest of her family. They were always having to cater different meals, and that was really, really difficult for them. And she really came to me. She wanted to improve her symptoms and she wanted to expand out her diet. So what did we do? So I requested a fecal calprotectin to just double check for pouchitis. That came back normal. I also, because she had fatigue and she hadn't had any blood test done basically since her surgery, and not any nutrient blood tests done anyway, I wrote to the GP and I requested that they look at her vitamin D, her B12 and her iron, and we did a full blood count as well and everything else. And actually, interestingly, what that showed was that she was deficient in vitamin D. She had really borderline vitamin B12, and she had really borderline iron stores as well. And so it was quite clear to me that potentially that all those things, so low vitamin D, borderline B12 and low can massively contribute to fatigue. But also, if she was having watery bowel movements, she was getting dehydrated as well. That can contribute to fatigue. And so what we did is we worked together with the GP to correct those deficiencies. And we also worked on supporting the thickening up of her stools to try and reduce her bowel movements. And we expanded her diet. She was very much on a very beige, bland diet, and we moved more towards a Mediterranean style diet over the period of a few months together. And what did we see as the outcome for that? So we managed to get her bowel movements from 10 to 15 down to 8 a day, which she was happy with in the end. Her fatigue massively improved and she felt much better, and her overall well-being and quality of life improved, and she was able to eat meals with her family. She wasn't having to cater for different family meals, and they could all sit down and eat the same thing. And for me as a clinician, I think it's those things that I find like the best and biggest wins for patients. It's not about, although it is important, like improving number scores on nutrients and stuff like that. It's actually about like how food can impact our quality of life. And if you're not having to cater for other things and you can sit down as a family and enjoy a meal, or you can go out and you can not worry about what you eat, that for me is like the biggest win and the best thing that we can do. Okay, so that comes to an end. I'm sorry, that was a real whistle-stop tour through nutrition for pouches, but I hope that you learned something new today. I hope that there was something useful that you could take away. I hope also that there might be lots of questions. As I said, it's a massive topic and it's really difficult to cover it all in just half an hour. I've gone 7 minutes over, but yeah, really look forward to having a good Q&A session and helping answer the questions as to the best of my ability.
Well, that was spectacularly fabulous. Thank you very much, Clemmie. On behalf of everybody who's watching, talk about a whistle-stop tour. And I'm sure there's a massive amount of information there for people to reflect on and digest.
Yeah,
Joke for the night. No, I'm here all week. We have got some questions, but I'm going to start because I'm selfish like that. When you look at fiber and you look at the care that pouchees have to exercise, particularly new pouchees with regard to fiber, there's one key message that we give over and over and over again, which is to chew. And I wanted, because for all the advice that you've given with regard to fiber and the importance of soluble fiber versus insoluble fiber, chewing, would you like to comment on chewing as a tool that pouches can use to avoid problems with digestion of
Yeah,
fiber?
totally. David, you bring up such a good point there. And also what I wanted to say to everyone is in terms of like the fiber advice, that's if you don't have any complications. If you have any complications like trouble emptying your pouch, if you have any strictures or narrowings or anything like that, then it's really important to get personalized advice and get support from someone if you start introducing food so that you don't put yourself at risk of obstruction. So this is very much based on like, if everything seems to be okay with your pouch and there's no complications, then those things should be okay for you. But just coming back to the chewing, David, it's something that I bang on about loads to my patients in clinic. If food, basically quite simply, if food starts its journey off well here, it's going to have a good journey through our system and then through our pouch and then out the other end. So I often say to my patients, like, you've got your best free blender right here with your teeth. And chewing our food means that we get more nutrients from it. It means that we break down those particle sizes as well. So if there are any issues internally with narrowings or anything, it's about, if you've got a hole that big, you can't have something too big trying to get through it. Actually, if we can chew our food really well, that's going to help things move through the digestive system more. And also what I definitely see with chewing is that it can be a real game changer for some people when it comes to bloating. So if people aren't chewing well and they're eating quite fast and they're eating with distractions, it means we can swallow quite a lot of air and we're not breaking down our food properly. And then that doesn't have a good journey, like as it moves through the system. And actually, for a lot of patients, quite simply, just taking time to chew their food can be like, it's so simple. And some of my patients are like, I can't believe you're telling me to chew my food. But I'm like, honestly, trust me on this one. It can be a really transformational one.
Yeah, brilliant. And one of the, I'm going to be selfish again before we jump into the questions. Diaries. Do you advocate the use of diaries, food, drink, poo, by way of trying to identify and correlate good versus bad foods?
So, yes and no. So, I use them in clinic. I get every patient that I see to do a week-long food and symptom diary for me because I have the experience and the qualification to be able to analyze that and to be able to like put two and two together and make four. The issue a little bit is if we write our own food diaries, is sometimes we don't have the knowledge to then put two and two together, and we may end up putting two and two together and making five, and then restricting our diet unnecessarily.
Yeah.
So I think sometimes it can be quite helpful in some instances, but if you look at it and there's no super clear pattern, and you're a bit confused, like the best thing to do is actually just get help from someone who can read it properly and then can advise you off the back of that. So I think they sometimes can be useful, but sometimes not. So I'd caveat it with being
Interesting.
about reducing
Yeah.
foods unnecessarily. But
Yeah.
it's sometimes for people, they might write a food diary and they might really clearly see that every time they eat
Yeah.
this
Yeah.
certain thing, that triggers symptoms. And that can be really empowering for patients.
Yeah, great point. I mean, we talk about that correlation, but actually, most foods are quite complicated, aren't they? Most meals are quite complicated, and that's a really good point. We get a few comments here, quite a few comments about the lack of nutritional advice, diet advice for pouches generally. I mean, I think you and I think certain dietitians absolutely stand out, like Gabriella Pufu at St Mark's,
Yeah, she's
stand out
brilliant.
as being exceptional in this regard. But for your average punter, your average pouch punter around the country, they wouldn't necessarily have access to you. Although we are going to ask for your contact details at the end again. But have you got any advice about accessing good nutritional dietary advice for pouchees? Is there any magical method that people all around the country, outside of the UK as well, we have a huge membership all over the world. I mean, how do you get good pouch related nutrition advice?
I wish there was a simple answer to it, but I get so frustrated myself at the lack of specialist dietetic services. In the UK in particular, it's a funding problem and it's a
Mhm.
postcode lottery,
Yeah.
and it shouldn't be the case. I think like my view is that anyone who has pouch surgery, like must see a dietitian. Anyone who has any kind of bowel condition must see a dietitian, but that's simply not happening. And actually, even the British Society of Gastroenterology now, they released their new guidelines for the treatment of inflammatory bowel disease, and 2 weeks ago, and they are now saying that nutrition guidance and dietetics should be part of the care package. But the thing is that being given as advice and then actually putting that into practice is we're miles away from that basically. So it upsets me that people aren't getting support. And at the moment, there isn't a like go-to pouch diet resource, like a good evidence-based resource hub. Maybe you've just given me a business idea. I
Mhm.
don't know. But I think that it's really hard. And I come see us is
Yeah.
like the
Yeah.
try and ask for a specialist dietitian within your clinical team. Hopefully, you might get one. If you don't have one, then the next best thing is to see a private clinician. So to come
Okay.
to us.
Okay. Do people get referred to you? Do you get referrals?
Yeah, so we work with quite a few surgeons and we work with quite a few consultants who, mainly in the private sector, who refer patients to us who they think would benefit from nutrition support.
Okay. So it's not NHS. It's not public. Okay.
No,
So it's
unfortunately
privately
not.
funded. You've got
Yeah.
a you've got a cough. You got to cough the wonga. Yeah, okay. That no, it's just to understand that. That's all
Yeah,
right.
yeah, no, I'm
Yeah,
unfortunately we're
yeah.
not
No, no, no.
yeah,
I get
over
it.
on the
That's
NHS.
all right. You don't need to apologise. That's your business. That's your business. All right. So jumping to the questions, there's some great ones here. I mean, a lot of this will resonate with pouches. So Helen asked, she gets bloated after eating anything. Would an allergy intolerance test be a good idea?
Such a good question. I'm so glad this has come up.
Mhm.
So first of all, I'm really sorry that you're experiencing those symptoms because that's really unpleasant that if every time you're eating, you don't feel well, because that just takes the enjoyment out of food. But what I would say is please, 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 if everyone only takes one thing away from this session today, is please don't waste your money on food intolerance tests. So
Ooh,
the
okay.
ones that you can
That's a maybe then.
see, sorry.
That's a maybe then. Okay.
No, it's
Okay.
this is like a black and white. Don't do it. And the reason for that is that despite the really clever marketing and the expense of these tests, any evidence-based practitioner that you see would never recommend them. Um, I
Mm.
won't go into like huge complexities. Actually, on my website, I wrote a blog about it. If you're interested to understand a bit more about it, then you can go and find it there. But basically, the part of the immune system that they're looking at doesn't actually show food intolerance. So they look at a specific immune molecule called IgG, and they suggest that higher levels of IgG indicate food intolerance, whereas actually most of the literature shows that it just shows food exposure. So it shows that the body has had exposure to that food. It's not a reaction in any negative way. And I often see if I haven't got patients before they've spent the money on it, they come and they say, I've got this test result and it's just coming up with everything I eat all the time. And how could I possibly cut out all those foods because I won't have anything to eat? And I'm like, whoa, we don't need to cut them all out. It's basically just showing you've had exposure to those foods. So do go over, if you want to understand a bit more about it, you can go over to my website and read a blog that I've written about it, which will give a bit more detail. But basically, don't do it. And what I would say is, I think if you're experiencing those kind of issues, it is good to speak to someone to help. So to see if someone can help investigate what might be going on. First and foremost, maybe it's good to go and see your GP and see if you can get referred back to a gastroenterologist or something. It may be that they can run some tests to see if there's anything else going on for you. I would often, most people have had a celiac screen at some point. If you haven't had one though, maybe that's something to rule out. And then there are other things that can cause things like bloating, which a gastroenterologist will be able to look into for you. And then I suggest that, again, as I said, diet can, and having someone investigate for you in terms of looking into the way that food might be reacting for you or what you might be eating and how that might be triggering bloating for you, that might be helpful to do too.
Okay, in terms of swallowed air, is that what you're thinking? Yeah.
As in investigations.
Well, the comment is every time they eat, which is really odd, isn't it? Because that would encompass a wide range of foods, presumably, and it's odd that it's every single time that
Yeah,
that would
and
apply.
look, it might be something, it's difficult to know without any other information.
Yeah.
It might be
Okay.
something around like food environment and how you're eating. It's potentially something to do with something going on inside. And that's why maybe it's useful. So sometimes we can get bacteria growing in the wrong place when we have pouches.
Yeah.
And so they can actually, larger numbers of microbes can start living in the small bowel where they're not meant to, and so that you get lots and lots of gas and bloating and pain every time you eat different foods. And sometimes, so it's called small intestinal bacterial overgrowth. And sometimes people can get that. If you go to gastroenterology, they should run a test for that, and then they can provide antibiotics to help to reduce that for you. And again, there's dietary interventions that we can look at in terms of potentially helping to support that.
Okay. Brilliant. Thank you. Colin, a regular visitor, great friend of ours, worried about eating salads with so many undigestible foods with skins. Is there a safe way to eat salads? And just tied in with this is Gwyneth, if I can scroll up quickly enough. Gwyneth talking about she's 8 weeks post-surgery, trying to introduce fruit and veg, but a bit nervous. In particular, some advice to avoid tomatoes. I mean, I think we've probably all had advice 8 weeks after surgery to avoid stuff. So this is a general question, but particularly because tomatoes can give you butt burn. So you're looking at salads and tomatoes in the case of this question. Um, One is butt burn, one is generally the perils of eating salads when you've got all that fiber in there.
Yeah, okay. So I guess like first and foremost, it depends where you are on your journey as to how appropriate it might be to introduce different foods. So if you are 8 weeks post-op, you're still quite early days in terms of introducing really rough textures. And often it's better to start introducing softer foods first. So for example, if you're 8 weeks post-surgery and you're a bit nervous about starting to introduce fruit and veg, if you haven't had any at all, then go for your softer ones. If you like, maybe you've had bananas, but if you haven't had them, they're a really good one to start with because they're nice and soft and soluble, and generally they're really well tolerated by lots of people. And again, start with like I often talk to patients about different stages of introducing stuff. So if we take the apple again as an example, when you're first trying that apple, peel the apple, cook it, and have it as like a stewed apple, basically. If that seems to go down okay, then the next stage would be maybe to try a quarter of that apple without the skin, raw, chew it really well, see how that goes down. If that then goes down okay, try the half an apple without the skin, and then move on up through that. And also, again, just coming back to what I said in the slides about having a small amount to start with can really help with confidence. I totally appreciate and work with patients all the time that feel really scared post-surgery. And I've been there myself as well, being really scared post-surgery about not wanting to rock the boat at all. And actually, it can feel a bit easier if you break it down. So just focus on one food. So if we're talking about bananas, for example, try like a third of a banana. Just eat a little bit of it, chew well, don't do anything else, see how that goes down. And what I see with patients is the more that you can do that and then you build up, then you build your confidence as you go. And suddenly then within a few weeks, you're flying and you're trying lots of different things and you've just feeling a bit more confident about it. I think often people like get the fear massively put in them about obstructions. And of course, we have to be very conscious that there is a higher risk of them post-surgery. But I also think people need to be given the education that actually once everything's settled down and things are okay, as long as you don't have any complications, that actually you should be okay with more textures. So that's kind of that side of things. In terms of the salads, sorry, I'm a bit of a like waffler,
Right.
but this
No,
all
that's
often
all
like
right.
loads of
That's all
nuance
right.
to this.
Yeah, yeah. Well, we're okay to continue. It's 8:30 now, as long as you are.
Yeah, I'm happy to continue. That's
Yeah,
fine.
great, because there's a few real key questions still to
Okay,
come.
cool.
So
So
if you,
I'll try and be quick through this. But in terms of
yeah,
introducing salads, so I have worked with lots of J-pouch patients who and pouch patients who end up being able to eat salads absolutely fine. In terms of like the fiber and the texture. And I can see a couple of people nodding and like saying that actually they're okay with that. So often people can. What you might see and what a lot of people become fearful of is you might see that salad come out in the loo, quite similar to the way it went in. And don't be alarmed about that. That's completely normal. There are certain parts of foods that we don't digest and break down ourselves. That's that insoluble fiber part. And that when you have an entire colon also comes out whole, but you just don't really see it because the stool's all formed. So don't be alarmed if that happens. It doesn't mean that you don't tolerate that food. It's just like it's quite a normal thing to happen. But if you find that you don't tolerate it that well, or you're a bit nervous about it, in terms of introducing things, so like cucumber without the skin, in terms of like your salad vegetables, I tend to find like butter leaf lettuce and things like rocket, if you chop it up small, that seems to work quite well for people. Also, don't forget that you can make salads out of cooked things. So things like roasted butternut squash, roasted root vegetables. You cool them and you make those into a nice salad. Things like green beans, olives, like Niswa salad's quite a good one because often a lot of the stuff in there is quite well tolerated. So there's definitely ways and means around having salads and still enjoying them when you have a pouch.
Fantastic. Okay, so we've got a theme that I'm going to ask you to explore about weight loss. And there are two elements that people are asking about. One is fasting and whether fasting is appropriate and safe for pouches,
Good question.
thinking about the 5-2, for example. And the second part of the theme is the use of taking of GLP-1
Okay.
inhibitors, is it? So Monjaro, for example,
Yeah, Ozempic and things.
hot off the press, and some anecdotal good reports about effects on pouches. So two thoughts on weight loss, as I say, fasting and Monjaro.
Yeah, sure. So, in terms of fasting, I don't know of any specific research data on fasting with pouches. So, I guess that's kind of first and foremost to say. What I would say is, like, if it works for you, great, but some patients might find that it doesn't work for them. Just in terms of our bowels don't really like being empty for long periods of time. And particularly if we have a pouch, often what I tend to see and what can happen is if you fast for a really long period of time and then you start eating again, you can sometimes then have very watery bowel movements because basically there's been no food going in through to absorb all the fluids and liquids that are still being produced in the digestive tract. That can then cause some of those unwanted symptoms. So I think what is important to remember is that fasting is no more successful in terms of weight loss than a calorie restricted diet because that's basically what it is. Like you shorten your eating window, so you end up eating less, so you reduce your calories, which is exactly what you do in a calorie restricted diet. But often people just find it easier because there's kind of rules around it. And it's like, I just don't eat then. And then I eat within this window and then you eat less. So it doesn't mean that you can't lose weight if you have a pouch, just doing it in like a more normal, conventional way. If you find that fasting doesn't work for you because of your pouch symptoms. I would also say it's potentially sex dependent in terms of whether it might be appropriate for you in terms of like female hormones. So a lot of the research in fasting has been in men, and the more recent research in women has suggested that it may not be so beneficial for female hormones, and that where there might be some positive benefits in men, sometimes you see the positive benefits in women, but you also see increased cortisol levels, stress levels, and that can have negative impacts on our health. So again, it's it's horses for courses. I would also say, as well as if you're shortening your eating window and you're eating less, you've got to make sure that when you are eating, that you're eating enough to sustain your nutrient requirements. That's the other problem that I see.
Yeah.
So it's not something I tend to recommend for people because I do think there are lots of ways that we can achieve weight loss without being that extreme.
Okay. Brilliant. Okay.
Oh, and then the GLP-1s.
Yeah.
Do you know, I am going to be totally honest with you. I don't know a lot about GLP-1s when it comes to J pouches. I just don't think there's any research in it yet. What I would say is I can't see from my understanding why there would be any contraindications to having them. Because it basically just changes your appetite. And so as a result, it changes how much you eat and the way you eat, and that sh shouldn't have too much of an impact on pouch function unless you really completely lose your appetite and then you're finding you're struggling to eat, and then that maybe affects your pouch output. then that's another thing to consider. But yeah, I'm just going to be totally honest that I don't know a lot about GLP-1s, and it's not something I've come
Yeah.
across in clinic yet.
I mean, we've had anecdotal comments on the Facebook group that it works well for pouchees.
Yeah, great.
It works by slowing gut motility, so a little bit like Imodium, I guess. So
Right.
it takes longer for stuff to go through the gut, and the end result of that, what manifests is that you don't feel like snacking, you don't feel like eating large amounts. So it's more about a feedback about controlling the amount you eat and reducing the amount you snack, and that's a really good thing.
Yeah.
So with no ill effects. I
No,
saw one.
totally. I think, look, these drugs are like a total game changer when it comes to treatment of overweight and obesity. But they've just got to be used in the right way. And I am like very pro them. But I am also really pro people getting nutrition guidance alongside them, because they work to a point if you continue to eat in the way that you've been eating before, and then you reach basically a plateau. And that's where that dietary education can really help to get you even further beyond there. And then at
Yeah,
some point, we don't know yet how long people can stay on these drugs. And
no,
if you don't change your diet and your lifestyle whilst you're on them to then continue to keep that weight off once you come off them, then we have a problem. Because when you then come off them, if you then, your appetite will go back to normal and you will then want to eat more. And if we haven't supported you to change your dietary patterns and habits, that weight will go back on, because that's what we see in all the weight loss research that we have to date, is that it is about making sure that people make those long-term sustainable changes. It may be that we can just use these drugs forever, in which
yeah,
it's fine,
yeah,
but we just
yeah,
don't know yet if that's the
yeah,
case. So I
yeah.
think
Indeed.
they're really, really good. But there's some support that's needed alongside them.
Yeah, yeah, brilliant. Thank you very much. All right, so a couple of questions on probiotics and use of probiotics,
Good question.
consumption of probiotics, whether they're good, in particular with pouchitis, but also as a comment here from someone who's 3 weeks post-op, everything's going straight through them. Would probiotics help to build up the pouch biome?
So, generally, in terms of probiotics, when it comes to pouches, there is some evidence that they may be supportive. Um, they are available in some NHS trusts and are not available in some. Some surgeons recommend them, some don't. The level of evidence isn't like top class, and that's why a lot of people say, oh, we just don't have enough evidence to recommend them. They're also the ones that there's only really one probiotic that has, or there's a couple, but there's one like main brand that has evidence to support its use in reducing risk of pouchitis, and potentially supporting with treatment. It's quite expensive, and a lot of NHS trusts don't have the budget to pay for it, so they don't believe the level of evidence is high enough to warrant the cost of it. But I do see some consultants recommending them. And if we think back to what I was saying earlier about how we can potentially support the health of the pouch, is supporting that microbial community. And if we're putting in like healthful, supportive bacteria through a probiotic, that's going to really help support that healthful community within the pouch. So it is something that I do use quite frequently in clinic. Some patients find it's helpful, some patients don't. So yeah, so that's that. I don't know if it's, I don't know if I'm allowed. I mean, I don't have any product affiliations. I don't know if it's helpful for me to like say what the product is.
Absolutely. I mean, you can't leave us hanging there. Like, yeah,
So in all the research papers that you see, and in a lot of the articles online, you'll see it being called VSL, like hashtag number 3. It then was renamed as Vivo Mix. It is about 3 months or 4 months ago been renamed again to CDS22 formula.
Yeah, CDS 22.
It can be bought it's like a website called probiotic.co.uk. They are the only ones that seem to sell it at the moment. So the reason that is the original formulation, the CDS22. The scientist is called Jerome de Simone, I think.
Yeah.
He That's his original formulation that he used in the clinical research trials. It's what all of the like European Crohn's and Colitis Organization, all the probiotic advice guidelines are all saying that it needs to be the original de Simone formulation if you're going to use probiotics, because the other two now are still being marketed and still being sold, but it's not the original formulation. So the positive effects that you might see might not be as good as if you take the original formulation. So that's that. And what I would say to your lovely attendee who's 3 weeks post-surgery is I would always be asking your surgical team before you do anything like taking probiotics to see, like, is that something that they'd be happy with, or do they see any contraindications for you to take it? What I would also say is 3 weeks post-op. I know what you're experiencing is really not fun, but it's your really, really early days, and it is often quite common to experience looser bowel movements. Talk to your pouch nurse or your surgical team if they haven't had the conversation with you about fluids and proper hydration, something I didn't manage to cover today, but it's hugely, hugely important. And also maybe some Imodium or loperamide, if that's not something that's been discussed with you, to help to support that.
Actually, that particular question, I just want to expand on that. They also asked about vitamin supplements, given that everything they eat is flushing through them as their body adapts to its new plumbing, and that'll take a while. Are there any vitamin supplements you would suggest?
Yeah, so what is important to remember is that although it might feel like everything's going straight through you, like when you eat, you're then like rushing to the loo, it's not actually the food you just put in your mouth that's coming out the other end straight away. So you will be absorbing some nutrients as it moves through the digestive tract. So basically, when we eat food, it sits in the stomach for about 2 to 4, maybe 5 hours, and then it takes about between 2 and 4 or 5 hours to move through the small intestine. So when we eat foods, it sends a signal to get our bowels moving, which is why it sometimes triggers a bowel movement and it triggers us to go to the loo. So it won't be flushing straight through. You still will be getting some nutrients from your food. It's just that things aren't thickening up and staying in the pouch for long enough for the water to be absorbed. If your diet's very, very restrictive, and you want to take some kind of multivitamin supplement, I'd ask your clinical team if there's something that they recommend. If not, I wouldn't suggest post-surgery to have tablets. I'd suggest some kind of dissolvable multivitamin might be a good idea, just in that immediate aftermath post-surgery.
Excellent. Thank you very much. I'm seeing a question about serotonin. I'm not ignoring it. We'll come to it. Don't worry about that. But there's another question here relating to weight, I think, and it's the other side of the coin from what we were discussing before about weight loss. So this is a comment from someone who had FAP, had the colon removed aged 15, eats very healthily, and is fit, manages everything marvelously. This is her daughter, by the way. No matter what she eats, she's always hungry and she's very, very slim. So, any tips on how to stop things going through so fast, or indeed just weight gain in general for those people who have that issue?
Yeah, sure. So I think we need to be looking at, like, how do we slow things moving through the digestive tract? Things like loperamide can be really helpful for that, but also, again, like those soluble fiber foods, those kind of things that slow things up. Also, really making sure that you're getting a lot of bang for your buck when you're eating foods. So in that respect, I mean, like when you're eating, what can you add to your food to increase that energy density of that food, or like in simple terms, like increase those calories? So for example, if you're cooking, can you use like ad lib olive oil? If you're trying to gain weight, like fat is like gram for gram, like most calorie dense. So can you include like some extra cheese? Can you include like ad lib olive oil or drizzle in olive oil? Can you include things like nut butters, like those kind of stuff? And don't be afraid of portion sizes with them, as long as you can tolerate larger portions of them. And really make sure that everything that you're eating is that really energy dense food. Eat regularly. So having like food every 2 hours can be helpful as well. And also then if you're still struggling after that, it always comes back to it, but like seek out support. It may be that there's something underlying that's going on. It may be that you just need some specific support to have a look at what's happening.
I think I could open an equivalent clinic to yours, advising people how to put on weight. I seek to manage it, no problem. You know, chicken tikka masala, rice, Guinness, and Haagen-Dazs ice cream is my key, with obviously lots of chewing. Let's ask the question about serotonin, because that's been asked twice now. So this is more about physiology, I think. I don't know if it's in your area strictly, but is there a need for pouches to think about serotonin supplementation, either dietary or,
Do you mean serotonin, as in
yeah,
the
sorry,
hormone? No, no,
serotonin?
no, it's fine. I just was like, oh, this is something that I haven't heard of.
Oh, that's the
Um,
American pronunciation.
No, no, no. So it's fine. No, no, no. It's okay. What was the question? Is there a need for
Is there a
serotonin?
need for, yeah, because I think serotonin is manufactured in the gut, isn't it? I
Yes.
don't know, it's a physiology one.
Yeah, yeah. So there's a bit of confusion. So serotonin is known as the happy hormone, and yes, about between like 70 and 90% of it is manufactured and made in the gut, and like other parts of it are used in the brain. My understanding of the physiology of it and the research around it is that serotonin doesn't just work in the brain. So it's not like your gut is producing serotonin, that it's traveling up to the brain and that's like what's happening. Actually, there are serotonin receptors in the gut, and serotonin isn't just in our body to make us happy. It actually helps our gut muscle contractions and loads of other things. So the the serotonin being manufactured in the gut is for gut specific purposes, rather than it being crossing the blood-brain barrier into the brain to support that, although maybe some of it does go there. So don't necessarily, I don't think there's any evidence in terms of having to take supplemental support for that. I know that some patients can find SSRIs, so serotonin like reuptake inhibitors, so they're
Yeah,
antidepressants. They can be quite helpful,
yeah,
but again, like it's not super clear in terms of the understanding of how that works. But I guess it's just the clarity around the serotonin produced in the gut. The understanding from the evidence is that's actually just used in the gut, and
yeah.
that it helps with things like the gut workings. And it doesn't mean that if you don't have half your gut, that you don't have half the serotonin that your brain needs, basically.
Okay, brilliant, brilliant. Um, we're getting there. We're getting there.
Oh, I thought
Um,
someone saying should pouches be on antidepressants? No, not necessarily. Only if you have issues with depression, and that's something that a clinician thinks would be helpful for you. But it's not like a blanket thing that everyone should be. Sorry if that's the impression that I gave. That's
No,
not
no,
what I
no,
meant.
that's very clear. Very, very clear. So you don't need to be on antidepressants because you've got a pouch. All right, that's very, very important. Let's talk about oral hydration. And there's something called the St. Mark's rehydrate oral hydration stuff. And there's first of all, question is it valuable? Is it good? Secondly, is how do you make it taste palatable? Basically, a lot of people think it's disgusting.
Yeah, no, I get it. It tastes hideous. Like WHO, World Health Organization, Hydration Solutions, St. Mark's Solution, all of those really helpful. So, in order to promote adequate hydration and fluid absorption in the gut, we need a specific amount of water. salt and sugar, which is exactly what those hydration solutions bring together to encourage optimal fluid absorption in the gut. So they are absolutely brilliant for people without a colon who, which is obviously one of its jobs is to absorb fluids. And particularly post-surgery. So the lovely person who is 3 weeks post-surgery and having lots and lots of bowel movements, actually they should be supporting themselves with some oral rehydration solutions to help to reduce that. And so yes, they are good. In terms of palatability, I actually think that it's quite hard to make it palatable. What I would say is super chilled cold. So
Mm.
make it like put it in the freezer and drink it so it's super cold. The other thing is actually there's a really good brand. Again, I don't have a brand affiliation, but I always think these things are useful. Um, uh, so there's a really good, lovely colorectal dietitian who has worked with a stoma patient to formulate a product that is specifically for people without a colon, and it's based on the St. Mark's solution. And what I've done loads of research into hydration solutions available on the market. Most of them don't cut the mustard and aren't the same as the St. Mark's solution. Most of them don't have adequate amounts of that water, salt, and sugar that they need. Whereas this one does. So it's called hydrostomate.
Hydrostomate.
Hydrostomate. So HY.
Hydrostomate.
So bad at doing mnemonics.
Hydrostomate.
Hydrostomate.
Yeah.
Hydrostomate. So it's been
Okay.
specially formulated, and it's much more palatable than anything else I've tasted.
Mm.
And it's the only one I feel like I can drink on a regular basis. It is going through the process of hopefully getting some NHS funding and being available on prescription at the moment.
Mm.
That's exactly how you spell it. So that can be quite a good one if you're struggling, but obviously there's a cost that comes with that. It
Yeah.
is cheaper to make it yourself at home.
Yeah.
And what I would say is make it super cold. And if you want to flavor it a little bit with some squash or something, that might be okay too.
I mean, I heard of some pouches with high output and stomates.
Ostomates.
Ostomate, sorry, with high throughput, getting through liters of the stuff, liters a day. You know, having making it fresh each morning, putting it in the fridge and drinking it and making sure they get through liters a day. You know, it's really good. A good comment there from Colin about if you've got diabetes, are you safe? Is it safe to be having?
Yeah, that's a really good question. So I guess first of all, what I would say about the St. Mark's solution, if you've got, I know we're not talking about high output stomas, but if you've got a high output stoma, or if you're like high output pouch, basically, there is, and again, this needs like proper nutrition counseling, but there is like a certain restriction on fluids. So drinking liters of the stuff isn't the right approach. Actually, like drinking the majority of your fluids like based on your weight into Mark solution is good. And then some normal isotonic fluids, and then adjusting that as your stoma or your pouch adjusts is useful. But again, that's really patient specific in terms of what we should be doing.
Yeah.
And in terms of, yes, so if you have diabetes, we do need to be quite careful when it comes to blood glucose control around taking hydration solutions. And again, that is very much something that needs like personalized nutrition guidance. As in, like, it's very personal on how well someone is controlling their blood glucose already and what their clinicians think is appropriate and all that kind of stuff. So really, we need to work in a multidisciplinary team to work out what's best for that patient.
Yeah, a bit more complicated, isn't it?
It's a bit
Okay,
more complicated.
we are almost there. We are almost there. So
Good.
you've done amazingly well.
Oh,
Right,
there's been some really great questions. I'm so glad that everyone's asked so many great questions.
there's one that I'm a bit confused about, and it's relating to taking vitamins at night because they stay in the gut longer and therefore probably better absorbed. I don't get that one. I don't understand that one, but it was from a doctor, so we all know it must be true. Um, I'm confused why that would be the case.
I'm not. convinced that I'm just trying to think. I don't think that's correct. As in, like, I don't think that things stay in the gut for longer necessarily at night. It's just that you don't eat at night, and hence the like eating earlier in the day. So there's just nothing going through the system so that you don't pass a bowel movement. It's not that everything like super slows down at night.
No,
Um,
okay. Yeah.
Generally, also as well, in terms of some supplementation, so things like iron, for example, are actually better taken in the morning in terms of optimal absorption.
Yeah.
So,
Clemmy, I think we've come to the end of the questions, which have been brilliantly negotiated and thoroughly answered by yourself. So thank you so much. Thank you so much for a fantastically informative um, talk. I was going to say entertaining them, but it's not really entertaining, is it? But
hopefully, it's been entertaining too.
absolutely fascinating for us. You know, food is so important to pouchees. If I had a penny for every time we got on the J Pouch Facebook group questions that are diet related, I think that I'd be a wealthy man. So first of all, thank you so much on behalf of everybody here and everybody who watches, downloads, and watches the recording. Thank you very much for your time and for taking the time, and it's been an extended by half an hour to answer all the questions, which I know that everybody who asked the questions will be very grateful that we got through them all. So thank you. There's some lovely comments on the chat.
I'm going to
Uh,
add my, people are asking for the, I am going to add my website to the chat because
yeah,
I know I
please
mentioned
do.
that
Yeah,
article.
absolutely. I'll witter on for a minute more, a couple of minutes more.
I'm
And
going to put my
whilst
email in there as well in
okay,
case anyone wants
yeah.
it.
So, just a couple of reminders, if I may, in the last couple of minutes, just for upcoming Red Lion Group events. First of all, our next open forum is on 4th of August. These are phenomenally wonderful. We get about, I don't know, 15, 20 pouches dialing in, a mixture of new and old, and it's a really great informal opportunity to chat. So that's 4th of August. We've got 28th of July, 7:30. Guy Worsley, who's a consultant colorectal surgeon and has done a lot of research on pouch related topics. He's going to be talking about the pros and cons of pouch surgery and some of the research that they're currently doing at St Mark's in terms of investigating aspects of pouch life. 13th of August, get this one in your diary. 13th of August, Janindra Waru Savitani, consultant colorectal surgeon at St Mark's Hospital. Well known to many of you, I'm sure. He's been a great and loyal supporter of Red Lion Group over the years, and he is one of the UK's, if not the world experts on pouch surgery, so and pouch care. He's going to be talking about a J pouch or stoma question mark, a life-changing decision. So in amongst that, there'll be great opportunity to hear from him on current trends in J pouch surgery, and also have the opportunity, as we've done tonight, to ask some questions and answers of the great man. So please take the opportunity to join us for that. All these events are on the events page on the pouchsupport.org website, which is the Red Lion Group website. I would also just like to mention a couple of events coming up. Clemmie is also speaking at the information day for the Kangaroo Club. The Kangaroo Club is a sister charity of the Red Lion Group, and it's always a pleasure to promote their activities and their events. And on the 8th of November, they've got a face-to-face meeting in Oxford. 8th of November, their information day. And Clemmy, I believe you're going to be talking at that one.
I'm talking twice, I think, at that one. So you'll
Talking
be so
twice.
bored of me by the end of the day.
Goodness me. There you go. And
I'm doing a professional one, nutrition, and then I'm doing actually a personal experience one as well.
there you go. So that's absolutely fantastic. So well done. Looking forward to that one. Those who can make it down to Oxford, it's always a great day out. Oh, I think that is it. So thank you again to Clemmy. Thank you to you all for dialing in. The recording of this event will be available on our YouTube channel and also on the website once Gaz has done the chopping and changing. But enjoy the rest of your evening, what's left, and thanks again to Clemmy.
Yeah, thank you so much, David, for having me, and thank you to everyone who joined. And I know someone's just put in the chat about people watching the recording that can't see the chat. If anyone wants to look up the article that I talked about with the food intolerance tests, my website's nalmclinic.com, NALM clinic.com. And if you want to get in touch directly, my email is clemmie@nalmclinic.com. But thank you so much for having me. It's been such a pleasure talking about a topic that's so close to my heart. So thank you.
Indeed, thank you so much. And it's really nice that you have a personal experience which really deepens and enriches all your messages. Thank you.
Thanks, David. Bye, everyone.
Bye.